Hi, good evening. Today I'll be presenting on ultrasound imaging in dengue fever in COVID pandemic. In this presentation, we'll be fully focusing on ultrasound as a method which going to assist us on the diagnosis and treatment in dengue patients. This will be my disclaimer. So the outcome of today's presentation will be we should be able to master probe position and interpreting formed image to guide us in our clinical assessment and treatment in dengue patients. As I know, here we have a mixed group of doctors who's listening to this CME. They might be a group of people who have no experience on using ultrasound. Some might have some experience using ultrasound, and some who never had a proper guidance teachings on using ultrasound. So in my presentation, I will start from the basic and we will move on to advanced in ultrasound in dengue patients. So the outline of my presentation will be two parts. The first part, I will touch little on the basics, the principle of ultrasound for dengue in COVID pandemic. Then once we covered some of the basic, we will move on into a detailed discussion on dengue patients, and we also will look into some of the pitfalls and some evidence that we have in our latest guidelines. So let's move on to my presentation, and this is going to be my first slide for my presentation, where this part I'll be touching a little bit on the basics. So we will talk a little bit on the equipment and cleaning, especially focusing on infection control as we are now currently in the COVID pandemic. Then later on we will move on into diagnostic ultrasound, and when we talk about ultrasound in dengue, there are few various types of scan that includes echo, IVC, lung, abdomen, especially looking at the perinephric collection and gallbladder. And if you see, there's a huge topics here which encountering ultrasound in dengue. So I won't be able to cover in detail all of this, but I'll try to pick up those are very important scans, especially focusing on dengue cases. So now let's talk about the basics of this ultrasound. If you see currently in this COVID pandemic, I are more comfortable to use a portable ultrasound. If you see what I'm using nowadays is a portable ultrasound, which is Lumify. So it comes with a probe and a wire, which I can attach this wire to a tab or phone. And the second important part is the cleaning of this instrument. So we can use a Sanicloth. Sanicloth is a non-alcohol base and is proven for coronavirus. So what we will do is we will clean the machine before and after scanning a patient, and the waiting time is 2 minutes. What I mean by that is you clean the machine, wait for 2 minutes to get dry, then you can use to a patient, and once you done your scan, before you coming out, you need to clean the machine again and wait 2 minutes to bring it out. And whenever I go inside to scan a patient, most of the time this patient will be a SARI patients or COVID patients, I will bring in a few packets of lubricant gel. But if you don't have lubricant gel and you have a bottle of gel, you can refill this gel into a syringe, 10cc syringe, bring it inside and you discard that syringe once you use. So if you look at this, the only two equipment which will be going in and coming out with me, that will be the ultrasound probe and the phone or the tab that I'm carrying with me, which I'll be cleaning it pre and post. So by doing this, we reduce the transmission, the infection transmission from one patient to another patient, especially in this current COVID pandemic. So, somehow we have covered about the basics of these equipments and how to clean the machines. Let's move on to a bit detail on ultrasound in dengue. So when we talk about ultrasound in dengue, as I mentioned earlier, we will be looking into echo, IVC, lung and abdomen. So I'll be moving into echo first. When we talk about echo, itself is a huge topic to be covered, and we may need a day or 2 days to cover the whole echo points. But as this is only a 30-minute talk, I will only focus in one window, that is parasternal long axis. I'm not going to cover on parasternal short axis or 4-chamber, which will continue with 5-chamber and 2-chamber view, and I'm not going to look into subxiphoid 4-chamber view. So let's only focus at one view and one point, that is about 3rd or 4th intercostal space, left sternal edge, and our focus will be looking at the LV function and LV collapse or LV kissing. That's one of the most common thing need to be picked up in hypovolemic shock in dengue. So this will be in this echo presentation. I think this will be the most important slide. I'm going to play a video where when I play this video, you need to focus on few points here, where how this probe be positioned on the patient, and look into the marker, how this marker is being placed to do a proper parasternal long axis view. Okay, so this will be a correct method where you will place your probe somewhere around 3rd or 4th intercostal, left sternal edge, about 1 or 2 centimeters away from the left sternal edge, and the pointer usually should be placing towards patient's right shoulder. Once you had that position, you may need to do a minor adjustment like swinging or tilting the probe to get a very good view. And you can see the patient can be positioned in the supine, and if you can't get a very view, you can even change the patient into a left lateral cubitus to get a better view. So once you position your probe appropriately for the parasternal view long axis, you will be seeing such image in your monitor. So I'm going to play the video. As I play the video, I will explain about the findings here. This is a normal echo. So you can see here the LV. That will be our main focus in this presentation. And you can focus on this wall. This is an infralateral wall, and this is an IVS wall. We are not going to look much into mitral valve, the mitral valve pathology, LA pathology, or right ventricular outlet. No, we are going to mainly focus on the LV. So this will be a normal echo. So when we are encountering a patient with dengue shock or patient with hypovolemic shock, most commonly we will hear ventricle kissing. So what is this all about? When the lumen of LV been obliterated and when the ventricle walls touches each other, that's when we come with the term of the ventricle kissings. That means the IVS wall and the infralateral wall start to touch each other where it is collapsed. And the LV will be very hyperdynamic, and the ejection fraction can be normal or higher normal, as it contracts vigorously to pump the blood to the aorta. And there are many papers that have proven this ventricular kissing, especially patients in hypovolemic shock, not only in dengue, even in other causes of hypovolemic shock. And whenever we see this ventricular kissing, is already an alarm sign that patients are already going into a shock. Maybe patients still are compensated shock, and if no proper fluid resuscitation, patient may go into a decompensated shock. So what we are going to see now is an example of a patient dengue shock in hypovolemic. Patients basically on compensated dengue shock. So let's focus on the LV function here. So you can see here, this is the ventricle, and you can see both walls are touching each other. That means these both walls are kissing. That proves that this patient have hypovolemic. So these two videos here. On my right side here, this is pre-resuscitation, patient in shock, and on my left side, this is post-resuscitation, the same patient. This is not a dengue shock patient, but this is just a patient who came in with hypovolemic shock. So the reason I'm showing is just hope you can differentiate the ventricular kissing in a shock and how the ventricular contraction improve post-resuscitation. So here you can see the ventricle touches each other, and here the contraction is quite good. So now we are going to look into a common pitfalls that happens when we do a echo to look for LV function, LV kissing. So what I will do is I will play the video first, then I will explain the pitfalls that you can understand better. So you can see here in this imaging, it looks like the LV is kissing, but in a real scenario, it is not, patient not hypovolemic shock. So what happening is the clinician actually not exactly had placed the probe at the middle of LV, but he's scanning at the end, at the side of the LV. So the lumen becomes smaller, the diameter becomes smaller, and it appeared as it is kissing. So when you have this kind of a situation, what we will suggest is try to slide your probe towards or away from sternum about 1 cm, so that you can confirm that your probe are exactly at the LV, cuts at the center of LV, to get a proper diameter and not looking at the side. So this is the common pitfalls that happens in LV function. And this is going to be my last slide for echo before moving towards IVC and lung scan. So here I've included a pericardial effusion. This is very uncommon findings in dengue patient, but the reason I included here is, as we are doing echo, I thought we just learn about pericardial effusion. As I play the video, you need to identify first the descending aorta, which I will be labeling it later. Then from the aorta, we will identify the pericardial layer. Once we identify the pericardium layer, the fluid above the pericardium layer will be pericardial effusion. If the fluids happen to be below the pericardium, then it's going to be a pleural effusion. So that's the most pitfall that happens in dengue, where they can have both pericardial and pleural effusion together. So I'm playing the video. So you need to identify the descending aorta. That's the round structure. Then the highlighted layer will be the pericardium, and the fluid exactly lies above the pericardium. And if the fluid lies below the pericardium, it's going to be a pleural effusion if it lies here. So that's how we differentiate between pleural and pericardial effusion. So now we are going to move to IVC. In this IVC scan, which is quite commonly needed and is quite important in dengue management, we again going to look the same thing. We're going to look at the probe position, the basic, the normal findings, how to do a normal measurements, and then we look at the pitfalls and the pathological part of it. So now in this video, again, I'm going to play how to position the probe. So here you have to again look into few things where the probe will be positioned at the midline. Then you can see the operator will drag the probe towards patient right about 1 or 1.5 cm. As we know, the IVC lies towards patient's right, as the descending aorta will be exactly at the midline at the center. So I'll play the video now. So you can see he plays at the midline. Then he drags the probe slightly towards patient right. So that will be the proper method. So here I'll be playing a video, exactly the IVC scan. So this will be the main three structure that you need to identify when doing IVC scan. That you must have a view of RA, and you will have a view of liver. Sometimes you will view of this hepatic vein here. Then you should judge your IVC. So in this video, we are going to look at the common pitfalls or the common mistake that all of us do is, or the biggest challenge that we have when we scanning IVC is, sometimes we mistaken scan the descending aorta and we start to measure the descending aorta instead of IVC, because these two lumen is lying side by side, and it's very easily, commonly you can do the mistakes. So what I'm going to do is, before we go into detail to differentiate between IVC and descending aorta, I'm going to play a video. At the beginning, I'm going to scan the IVC. After a few seconds, I'm going to drag my probe towards midline and I'm going to scan the descending aorta. So you try to view, and I think you must be able to differentiate how this IVC looks like and how descending aorta and how the pulsation of this descending aorta looks like. So let me play the video first. So this is IVC. There you can see the liver RA, and it's collapsing when I'm pressing. So now I'm dragging the probe towards midline, and you can see this is a descending aorta where it is pulsatile. The lumen is very straight, it's going a bit towards down. So let's look detail how are we going to differentiate these two anatomical structure when we scan in the abdomen. So usually if you see, the aorta will be smaller and it will be towards patient's right, and the IVC will be towards towards patient's right. This will be left at the center. The aorta will be circular in shape. The IVC will be a bit elliptical shape. The aorta will be pulsatile, as I shown the earlier video. IVC is not pulsatile, and IVC will be able to be compressed, where you won't be able to compress the aorta. And sometimes you can see when patient do a deep inspiration and expiration or sniffing, you can see the IVC will change, will compress. So this is how we differentiate to confirm that we are actually scanning the IVC and not aorta, because both will give a different findings, different measurements, and in patients who hypovolemic shock, the aorta might give a very good measurement, a bigger measurement, where the IVC might be collapsing. So now once we manage to make a good view IVC, and we are going to proceed with measurement. So how a proper measurement should be done? So if you see here, this is a proper way to doing a measurement here, where this is RA, this is your liver, and this is your hepatic vein here. So the measurement should be done at least about 2 or 3 cm away from this hepatic vein here, and the measurement should be exactly perpendicular. So if this is your lumen, your measurement should be really perpendicular, about 90 degrees. That's give you a very accurate measurement. And if you base on our CPG, dengue CPG, the latest CPG guideline, we talk about Cowell index. So what is this Cowell index in IVC measurement? So IVC measurement doesn't come as a single. It comes with two measurements where you should measure it on inspiration and expiration. Then we will calculate with a formula to look at the collapsibility. So how are we going to measure in inspiration and expiration is, when I get this view, I will click the M mode in the scan, and you will see a M mode will appear, and you will get a M mode picture. So I will freeze the picture, then I'll take the maximum diameter and I'll take the minimum diameter. So the maximum diameter represents on expiration and the minimum diameter represents on inspiration. So with that, for example, if I get 2 cm and 1.5 cm, I use the formula of 2 minus 1.5 divided by 2 times 100%. I will get my Cowell index. So this is a collapsibility index. That means the vessel collapsed 25%. Sometimes we do a eyeball rolling. Yes, if the collapsibility is very obvious, if collapse more than 50% or if it collapses 100%, yes, we can do eyeball rolling. But when the collapsibility is minor, very small collapsibility, we can't do eyeball rolling, and we by right should do a M mode measurement, and we use the IVC collapsibility index formula to get a very good collapsibility. And now the question back, why should we do this? Why should we measure IVC and why we should measure the collapsibility? So there are a lot of data have shown that the IVC measurement and the collapsibility really correlates with patient's volume status. So if you have a patient with a very small IVC and it collapses 100%, you can say that patient is really severely under volume. But if you have a measurement like 1.5 to 2.5 cm and it collapses more than 50, there's a room of roll of fluids. If collapse less than 50, you may say the patient is already in the euvolemic state. But if you see patient IVC is dilated 2.5 and collapsing less than 50 or no collapsible, then you may be careful that this patient may into a hypovolemic state. So this scan and this measurement may assist us when we deciding on fluid resuscitation, and will help us to decide how much fluids to be given and when to stop our fluid resuscitation. So I'm pulling out a paper that recently I went through. This paper actually looks into ultrasound guided fluid resuscitation in a sepsis hypoperfusion, not in a dengue but in a hypoperfusion, where they use ultrasound guided treatment, fluid resuscitation. So they had a two-arm. There's one usual care, about 100 patients, and ultrasound guided fluid management in another arm. If you see in this study, there's no much difference in the 30-day mortality, where 6 hours post lactate clearance was the same, SOFA score was the same, length of hospital stay was the same. There's no much difference between these two groups. Yeah, of course, because even the usual care also, they have given an appropriate fluid resuscitation. But when I look into detail on this paper, the rate of vasopressor, that means inotropic support, and the cumulative fluid administration over 24 hours was lower at ultrasound guided fluid management arm. This is the similar experience that I have when I use ultrasound in managing patient, where it helps me to avoid over resuscitate, and it helps me to avoid under resuscitate a patient. So what I'm trying to say here is a fluid resuscitation has to be done for a patient, but with ultrasound IVC scan, it may guide you to avoid from giving over resuscitate or under resuscitate a patient. Now let's move on into looking into other third space loss in dengue patients. So far we have covered echo, looking at the LV function for fluid resuscitation. We saw IVC scan, which and the measurement of this IVC, which help us in fluid resuscitation. So let's look into the third space loss when patient goes into leaking. And when it leaks, we commonly see pleural effusion. So that will be next few slides. We are looking at the lung scan. Pericardial effusion, I think we already done our echo earlier, and we have seen the pleural pericardial effusion. Then followed by I will show you few slides of kidney scan and the gallbladder scan. So again, before moving into detail of lung scan, I will touch one or two slides on the basics of lung scan. Then we will look detail into pleural effusion. So this picture actually have taken from scan in COVID patients, which is very useful. We do a 6-point scan on the right and the left, so total will be 12-point scans, especially in COVID patients. So we can use similar points when we scan for dengue patients. And patient can be either seated up or patient can lie down on supine position. So when we do scan, we need to place the probe vertically. So this will be a probe, and the marker will be pointing to the cephalic. So when we point the probe, we may need to get this bat wing sign picture in our monitor. Once we get a proper image, then only we can judge, is this patient's normal scan or does this patient have an abnormal scan. So why we call this bat wing? If you see, if you put a probe here, and this will be a marker here, so the patient's head is here. This is how image you get it. So this line is actually your ribs. So you can see a shadow, it's a rib, it's a bone, so there's no echo frequency transmitted beyond it, so you get a dark area. And this is your skin, this is your subcutaneous tissue, and here will be your intercostal muscle, and this will be your first anatomical structure that will be picked up by your echo. That is your pleural line. That is a line of your vesical and parietal pleura. And followed by that, we are going to look at the A line. So this is what they call as a bat wing, as they imagine as a shadow of this bat wing shadow here. And as I told you earlier, to be more detailed, this is your pleural line and this is your A line. So this is a normal structure that you get when you do to a normal lung. What is this A line means? When you put a probe here, the echo touches the pleural line. It goes back, then it comes down, and it reflects back the A line. As you know, the lung is a hollow organ, so every time it reflects back, it gives you an A line just to show that this patient has normal lung. When the patient have pulmonary edema or the patient have ground glass appearance, especially in COVID patients, you will see a B line, a vertical line. I'll be showing you in the next video. So this video is a lung scan of a patient of COVID, not a dengue patient. The reason I put up this scan is just to show you a difference between an A line and a B line, where this patient have a ground glass appearance appearing in the lower lobe, where the upper lobe was normal on the right lung. So here I'll be scanning his right lung and I'll be dragging the probe down towards patient's lower lobe, where you will see a B line appearing. So I'm scanning his upper lobe, A line. I'm dragging the probe down to the lower lobe and you can see a lot of B line appearing now, and there's also some pleural thickening. This is a very classical finding for COVID pneumonia. So you might be able to differentiate between A line and B line now. Now, before looking into pleural effusion, we must know curtain sign in normal lung. So what this is curtain sign, which is a normal lung shows. When patient inspiration, the lung extends, it overlaps the liver, and on expiration, the lung collapses and the liver will be seen in the scan. So here you can see at this angle a liver, here will be the lung, and at the middle you can see the lung will be like a curtain overriding the liver on inspiration, and the liver will appear on expiration. So I'll play the video first, so for you to appreciate a curtain sign which shows a normal lung without a pleural effusion. So this is a normal lung without a pleural effusion, and what we are seeing is a curtain sign. So now let's move on to pleural effusion. This is a dengue patient had a severe leaking and had a pleural effusion. So this will be liver. Here will be the hemidiaphragm, and this will be the lung, collapsed lung. So I'll play the video. So hope you can appreciate. This whole is a lung atelectasis collapse, and this is all a pleural effusion. So this is the hemidiaphragm. So I put it in a captured picture. So to appreciate a pleural effusion, because sometimes we may mistaken with ascites, so you must be able to appreciate a liver, or if you are doing on the left side is a spleen, then you must be able to see your hemidiaphragm. Then anything above hemidiaphragm will be a pleural effusion, and this will be your lung. Okay, so with this, I hope you can understand and differentiate between a pleural effusion and ascites. So now we are going to move on to abdomen scan. So in abdomen scan, two structure that you want to see will be kidney, looking at the perinephric collection, and we always know that perinephric collection of fluid accumulation around the kidneys very significant for patient bleeding and occult bleed and leaking. Okay, and then later on we will be looking into a gallbladder wall measurement. So this will be the probe position for the right and the left kidney, where you're going to put it exactly at that below around 11 or 12 rib space, and your marker will be pointing to the head, and the probe will be horizontal. So if you put it at probe position, you will get a kidney view and a liver. So the way you're going to differentiate is the liver will be more homogeneous compared to the kidney. So now here we are looking at the space between liver and spleen, liver and kidney, and we can see some perinephric collection. So this will be your kidney and this is your liver. So now you can see some perinephric fluid collection here, which is very significant in leaking and occult bleed in dengue patients. So now we are coming to our last part of our presentation, gallbladder wall thickening. This gallbladder wall thickening is one of a very good manifestation, which very significant to show the capillary permeability state, increased capillary permeability state. And whenever we scan and if the wall is more than 3 mm, it shows that patients are already into a severe dengue, possible of severe dengue, and patients are leaking. And when we see the wall thicken more, a higher thickness like 5 mm, it shows a very highly significant for patient to go into volemic shock. Even though it's a very sensitive measurement and very significantly, a lot of papers have shown that this is very significant to highlight patients leaking and shock, but this is not a very easy scan to be done. Even if you ask me, I prefer to do an echo, IVC, lung scan, and also look into a kidney perinephric collection compared to gallbladder, because sometimes it's not easy to scan and to capture gallbladder. Sometimes it's contracted after post meal, and if you see the measurement, it's very minute type measurement. It's 3 mm and towards 5 mm. So the difference is about 1 mm or 2 mm, and is easily mistaken by the operator. So you can have two persons to scan the same patient and they can come up with the different findings. So these have made a lot of difficulty for me to scan gallbladder. So I always try to avoid scanning this gallbladder wall thickening. But let's look into a patient. This is actually a patient. It was in a critical phase, and the patient have a hemoconcentration and lactate was 2.2. But there was no any much evidence of third space loss. So let me play the video. Okay. So this was the echo finding. The ventricle was good, not kissing. So then I proceed with abdomen scan. I didn't see any perinephric collection, but when I proceed with IVC, yeah, you can see it collapsed about 75%. So, and the IVC diameter also is not that great, 1.8 cm. So that have triggered me, is this patient into a hypovolemic, is this patient is leaking. So I did a gallbladder scan, and the wall, this is the wall measured, is 4 mm, which this suggested that this patient have a higher tendency to go into shock if we don't appropriately resuscitate this patient, and to measure the IVC after the resuscitation to look into the IVC collapsibility. But again, the gallbladder scan is very sensitive. As you know, the measurement may differ from one operator to another operator. So we need really to have some experience and should have been trained well before proceed with gallbladder scan. So with this, I would like to end my presentation. My take-home message today will be, we need a trained personnel, as accuracy of finding influenced by training and experience. That means it doesn't mean you just listen to this talk, you take a probe, you start scanning, you put a measurement and you start managing a patient based on the measurement you does. It may lead to a wrong pathway. You may need to have bedside teaching, one-to-one teaching, and you may need some experience of doing few numbers of scan before you independently to take a role of managing a patient based on your scan. And I think this point will be the most important point. You should take overall assessment, not fully dependent on single finding alone. That means IVC scan or LV scan alone is not a gold standard for us to fluid resuscitate. A fluid resuscitation or management are based on few parameters: clinical findings, your clinical examination, your all the laboratory findings, vital sign findings, plus your echo findings. So this your echo or scan findings. So your scan is going to be an added value to support your clinical findings and to help you on fluid resuscitation. So don't take one single scan, IVC or LV, and jump into a fluid resuscitation without looking into other parameters. And another thing most important in this current pandemic is risk of infection control. I think, as I presented on my first 1-2 slides, how to follow proper SOP on cleaning these equipments. So ultrasound is always should be integrated finding with overall clinical presentation, physical findings and laboratory tests. Thank you, and if there's any questions you can post here, so I will try to answer your questions. Thank you.